Okay. Well, again, good afternoon to everybody. Last time I was here, we discussed the topic of chronic hypertension and pregnancy. And today we're going to review a little bit of that and take the next step about dealing with patients with chronic hypertension who develop superimposed preeclampsia. So as a review, chronic hypertension is something that we, especially in the infant world, see on a daily basis. The prevalence in the general population and in the pregnant population in the United States has been increasing for a number of reasons. The increase is attributed to increased prevalence of obesity in our population, increase in the age of our population. Many people are becoming pregnant at older ages, and just comorbid health conditions. To diagnose chronic hypertension, it is a diagnosis either given prior to pregnancy or prior to the first 20 weeks of gestation. Generally or traditionally, we would diagnose somebody who had 2 or more abnormal readings of greater than 140 or diastolic greater than 90 on 2 separate occasions, at least 4 hours apart, unless faced with severe hypertension. But a number of years ago, our colleagues at the American College of Cardiology and the American Heart Association changed what their definitions and their criteria were for classification of hypertension. The new classification system is designated into 4 different categories. Category 1 is considered normal, and that's with a systolic blood pressure of less than 120 and or a diastolic blood pressure of less than 80. Category 2, which is considered elevated, is a systolic blood pressure that is between 120 and 129, with a diastolic blood pressure of less than 80. Category 3, which is stage 1 hypertension, is a systolic blood pressure between 130 and 139, and diastolic of 80 to 89. And category 4, which is classified as stage 2 hypertension, is a systolic blood pressure of 140 or greater and diastolic of 90 or greater. Excuse me. When making these classifications, if there's a disparity between the systolic and the diastolic, the higher value wins. Somebody who has a systolic of 135 but a diastolic of 95 would actually be a stage 2 or a category 4. Recommendations in the general population to initiate antihypertensive therapy are at stage 3 or stage 1 hypertension, especially if there's more than one additional findings, such as ongoing cardiac disease, diabetes, etc. So during pregnancy, sometimes the initial diagnosis of chronic hypertension can be somewhat difficult to get to, because it may not be just straightforward. In many otherwise young, healthy women, the first time they see a doctor in many years may be for the onset of their pregnancy care, and they could have undiagnosed chronic hypertension prior to that. The normal physiological changes in pregnancy can mask a previously undiagnosed hypertension. Remember that during pregnancy, both systolic and diastolic blood pressures fall, and this is a first trimester phenomenon. There is a significant decrease in systemic vascular resistance that occurs early in pregnancy. During the course of pregnancy, a patient's blood pressure may drop, with the lowest point coming between about 16 to 22 weeks. And then thereafter, the blood pressures usually gradually rise, such that by the end of the pregnancy, a woman's blood pressure is generally where it lives in the pregnant state or close to that. But if somebody has a previously undiagnosed chronic hypertension and experiences a decrease in blood pressure early in pregnancy, that diagnosis of chronic hypertension may be masked or difficult to ascertain until later in pregnancy. It's interesting to note that approximately 11% women with chronic hypertension may have other findings such as proteinuria that is above our cutoff for 300 milligrams, which we use to help diagnose preeclampsia. Therefore, somebody with chronic hypertension may be misdiagnosed as preeclampsia, but also it makes the diagnosis of superimposed preeclampsia more difficult if there is baseline proteinuria. Sometimes a true distinction between chronic hypertension and preeclampsia spectrum may not even be evident until after the pregnancy is over and you're looking at retrospectively. But interestingly to note that up to 50% of women who do have a diagnosis of chronic hypertension will develop or may develop superimposed preeclampsia at some point in time during pregnancy. The previous slide just showed the conditions of hypertension during the course of pregnancy. We reviewed that at the last meeting. So managing hypertension in pregnancy involves having a baseline lab evaluation, complete blood count, metabolic panel, electrolytes, BUN, creatinine, assessment of a proteinuria to establish a baseline. The gold standard is still a 24-hour urine, but a urine protein to creatinine ratio, if it's less than 0.15, can safely indicate that your 24-hour urine will be less than 300 milligrams and would be a suitable baseline. If it's more than 0.15, then a 24-hour urine would be recommended. Patients should be initiated on a low-dose aspirin, usually between 12 and 28 weeks, but ideally prior to 16 weeks for preeclampsia risk reduction. If chronic hypertension has been long-standing or is severe, a baseline assessment of the maternal heart is recommended with either electrocardiogram and or echocardiogram, especially for those that have poorly controlled hypertension for more than 4 years. Assessment of the patient's medications and to discontinue pregnancy unfriendly medications such as ACE inhibitors and angiotensin receptor blockers due to the potential complications and harm to fetuses. Our go-to medications for pregnancy tend to be either labetalol, nifedipine, which is calcium channel blocker. Further down the list, people still do use methyl-dopa. Diuretic use in pregnancy, hydrochlorothiazide is okay. Typically, we don't recommend starting diuretics during pregnancy, but if a patient is on one, such as HCTZ, it's not necessarily to discontinue it. As we mentioned last time, loop diuretics such as Lasix are typically used for routine management unless there's a significant underlying cardiac condition or patients are showing evidence of cardiac dysfunction. And one more slide, please. And then I reviewed this last time, updates on chronic hypertension management during pregnancy as a result of the CHAP trial from 2022 recommended that women with chronic hypertension treatment is initiated with a goal by BP of less than 140/90, rather than waiting until patients had severe range or close to severe range hypertension, as we would wait to treat previously. Treatment is now recommended earlier on in pregnancy, such that the goal is to be less than 140/90. And this is just a snippet of the Society for Maternal Fetal Medicine's takeaway point from that CHAP trial. So we said before, discerning the difference between a chronic hypertension exacerbation and superimposed preeclampsia is not always straightforward. Preeclampsia should be considered in a patient with chronic hypertension when there is a sudden change in her condition. And so we would have a high level of suspicion if there's a sudden increase of previously well-controlled blood pressures or a need for rapid escalation of antihypertensive therapy when someone has otherwise been previously well controlled. If there is new onset proteinuria, and obviously this will require a establishment of baseline earlier in pregnancy, but new onset proteinuria in excess of 300 milligrams per 24 hours could be an indication, or a sudden significant increase in proteinuria from previously known baseline. Would all be indications for suspicion for evolvement of or evolution into superimposed preeclampsia. And then, of course, any evidence of preeclampsia with severe features, such as severe persistent hypertension despite increasing therapy, thrombocytopenia, elevated LFTs, evidence of liver involvement with severe right quadrant or epigastric pain, new onset or worsening renal function, pulmonary edema, or persistent neurological symptoms such as headache or visual disturbances. So when you have the patient who you are expecting is transitioning from just chronic hypertension into the realm of superimposed preeclampsia, the initial workup is probably best done within the inpatient setting. Again, assessments are going to include your standard preeclampsia lab evaluations, assessment of proteinuria, serial blood pressure monitoring, and then of course fetal monitoring. And this initial assessment, can take up to about 24 to 48 hours before you're finally able to pinpoint and make a good disposition for the patient. In somebody who does develop chronic hypertension with superimposed preeclampsia, in certain cases, outpatient management may be appropriate as long as there's no evidence of severe disease. And outpatient management would include home blood pressure monitoring, as well as periodic visits in the office for blood pressure assessments, weekly or twice weekly preeclampsia lab evaluation, and then at least weekly fetal testing to assess baby status. For people who have diagnosis with preeclampsia with severe features, most would suggest that there's no role for outpatient management in those patients. And this is from the SMFM statement on hypertension checklist, just kind of going along in terms of management and delivery recommendations. So for those patients who, again, on the far left-hand side, fall into the category of preeclampsia without severe features, those are the patients who we often will monitor on an outpatient basis, as long as they don't have any of the symptoms of severe preeclampsia. For the middle column, patients with preeclampsia with severe features, meaning that they have the severe raised blood pressures and have evidence of severe features, renal insufficiency, pulmonary edema, et cetera. Those patients are usually delivered by 34 weeks or at least prior to 37 weeks if their diagnosis occurs after a 34-week mark. And then people who require either immediate delivery or delivery after completion of betamethasone fall into the third category there, which is persistent unresponsive high blood pressures, evidence of HELP syndrome, persistent neurological features, pulmonary edema, eclampsia, suspected acute infarct, placental abruption, bleeding, fetal death, and fetal intolerance. So with that brief review and management, we would open it up for discussion.